From a biological point of view, lung cancer is a quite aggressive form of human malignancy. This aggressiveness is due to a number of genetic alterations that drive the growth of this cancer.
Mutation testing has, by this, become mandatory before a decision of therapy for patients with advanced lung cancer.
Some of these alterations are extremely aggressive because they involve genes that are related to DNA repair. If a protein cannot repair the DNA, a number of additional alterations will be present in the tumor, and the tumor becomes more and more aggressive. So aggressiveness in tumors is due to specific alterations, genetic alterations. The main technology to detect genetic alterations in cancer for years has been conventional sequencing, also known as Sanger sequencing. Using Sanger sequencing, you can detect alterations in specific genes. Nowadays are available additional instruments that can detect several or many mutations in the tumors, and these new technologies are so-called multiplex platforms or next-generation sequencing technologies. These technologies are very powerful in that they can be used to detect hundreds of thousands of genes simultaneously.
A challenge in terms of tissue availability, because patients with advanced disease very often has very small biopsies, and very often the diagnosis is based on fine needle aspiration. Is that sufficient material for molecular testing? We know we need EGFR mutation testing, we need ALK testing, and in clinical trials we need more and more mutation analysis. Now the question is, how do we integrate all these things into clinical practice? The most ideal situation is, of course, we have multiplex technology which can put everything together, and we have to remember that mutations might not be the only driver of clinical interest. There might be other mechanisms and other assays which is clinically important.
The only thing is that they need a lot of experience, and they need a good staff of bioinformatics in order to manage the data, for data mining. They are becoming popular, but they are slowly becoming popular because they are quite expensive and they are difficult to manage. Now these instrumentations are quite expensive, and the reagents too, but we expect that in few years they will become cheaper. In 1-2 years it will be possible to sequence the complete genome in 24 hours with only 1,000 euros.
We need to integrate this knowledge into the treatment decision.
In comparison to first-generation sequencing, next-generation sequencing have several advantages. The main one is that with Sanger sequencing, conventional sequencing, first-generation sequencing, you usually investigate one gene at a time or few genes at a time. Whereas using next-generation sequencing, you can sequence hundreds of thousands of genes. This is the most important difference. Another difference is the sensitivity. The first-generation sequencing was not a very sensitive instrument. About 10–20% of the molecules should be mutated in a sample in order to detect them by Sanger sequencing. Instead, next generation sequencing can be used at a very high sensitive rate, allowing to detect mutations present in 0.1% of the molecules. Next generation sequencing has allowed to detect new mutations in known genes, for instance, EGFR, KRAS, BRAF. New mutations have been detected recently by next generation sequencing. But another interesting thing is that it has allowed to identify novel genetic mutations in different genes, not known as tumor gene before. There is a great expectancy versus next generation sequencing now, and probably in the future next generation sequencing will completely substitute Sanger sequencing.
More and more institutions are using next-gen sequencing, but do we have sufficient validation for making a treatment decision on this stage? That is a question. In my opinion, we need more validation in terms of clinical associations. Today, we probably need to use different technologies to cover the need. Mutation testing, we have sequencing, ALK rearrangement, we have FISH or immunohistochemistry, and we have other biomarkers which is based also on immunohistochemistry. But we are moving very, very quickly towards using a next-gen sequencing platform, as I said, which can meet most of the needs based on one assay, one platform.